Hi, everyone. This is Jean Birchman, your Executive Director, and I am very pleased to introduce you today to Dr. Ann Dudley. She will be giving another one of our speaker series, and her topic is surgical management of neurogenic bladder. Dr. Dudley is a pediatric urologist at Connecticut Children's in Hartford, Connecticut. She completed her undergraduate education at Yale University in molecular biology and obtained her medical degree from the University of Pittsburgh School of Medicine. She completed her internship and residency in general surgery and urologic surgery at the University of Pittsburgh Medical Center and completed a fellowship in pediatric urology at Vanderbilt Children's Hospital. She joined Connecticut Children's in 2017 and serves as the medical director in the Spina Bifida Myelomeningocele Multidisciplinary Clinic. She has a special interest in neurogenic bladder, hypospadias, and robotic surgery. Research efforts have focused on quality improvement, radiation safety, and urodynamic testing optimization. When not in the hospital, she enjoys spending time outdoors with her husband, their 2 young daughters, and their dog. So we'd like to thank Dr. Dudley so much for being here, and I am going to turn it over to her and let her walk you through her presentation. So thank you.
All right. Thank you guys so much. Let me go ahead and maximize this so you can see everything. All right, so as Jean mentioned, I'm going to talk about surgical management of neurogenic bladder. And this is something that as a pediatric urologist, we deal with very frequently and often is the source of a lot of questions for families, whether they need surgery, what the surgeries might involve. So I thought I'd give a brief overview and answer a few questions that were sent along in advance as well. So as an introduction, neuropathic bladder is often managed by catheterization, so passing catheters into the bladder, as well as different medications. And I believe one of our colleagues is going to speak a little bit more about the medicines and different things we can do without surgery to try to optimize bladder management. However, there are some individuals with spina bifida who may, whether for a variety of reasons, choose to undergo additional procedures or surgeries to help the bladder do its jobs. And the main jobs of the bladder are to store and empty urine. Specific procedures are tailored to each individual and after full discussion of the options with their specific surgeon. So my job today is to go over the things that are potentially options for patients and try to answer questions. So I always like to go back to sort of a little bit of history, and I think it's important to kind of realize that things such as catheters were not always easily obtained or easily used. The word comes from Greek origin to kind of let down or send down, so letting the urine out. And these are some examples on the right-hand side of some catheters that were made in the Middle Ages. However, we in urology like to credit Dr. Jack Lapides in the 1970s for describing clean intermittent catheterization, which is what most patients with spina bifida end up utilizing to help manage their bladder at some point during their journey. And this has had a profound impact on the way the bladder is managed, allowing intermittent emptying of the bladder and allowing some of the surgeries that I'll describe. So I think that's important to keep in the back of our minds. I also wanted to go over a brief anatomy lesson that just kind of talks about the things that we're going to be speaking about when we think about surgery. So at the top here are the kidneys. This is just a schematic, very simple. The ureter tubes, which drain the urine, the bladder that holds the urine, and the urethra that allows the urine to exit the body. And I'll talk about those different organs as we move forward, thinking about different types of surgery. Thinking about surgical goals, when I think about an individual, my goals are threefold, and there may be additional ones for each patient, but a lot of times we're thinking about the same end place. So I want to protect the kidneys that are dancing here and looking nice and strong. I want to make sure that there's no pressure on the kidneys. I want to make sure that the kidneys are able to drain freely and try to prevent any damage to the kidneys. And that's the number one goal. The number 2 goal is to try to improve continence. Our goal is to try to get children dry and to try to improve independence as a third goal, because in the end, we want to raise capable individuals who are able to manage their bladder themselves, if at all possible, and really allow them to play an active role in their treatment as we move forward. So a lot of questions I get from families when we start to think about surgeries or even at the very first visit. Often the question is, what surgeries might my child need? And as individuals grow and ask questions themselves, they might say, when and how? How do we do these things? So I'll first take a step back and mention that not every child needs surgery, but some do. And some require it to help the bladder. And the timing of that really depends on the reason why we're thinking about surgery. We also have a lot of different ways of doing surgery. We're very lucky in urology to have been pioneers of some of the different techniques. We can do things with little tiny telescopes and endoscopes. We can also use our laparoscopic or minimally invasive skills to use our surgical robot to allow us to do pretty complex surgeries through tiny little incisions. And then, of course, there is the traditional approach of making an incision and completing the surgery that way. And all of these can be utilized sometimes in combination, depending on what might be best for each individual. So when I think about surgeries, I always like to use the analogy of a balloon to describe the bladder, because I think it's something that most people are familiar with and allows us to talk about the things we're balancing in our mind to try to help make sure that the bladder is doing what it's supposed to. So first, the bladder has to store urine, and we want things to be stored at a nice low pressure, kind of like a water balloon, or those balloons that you can really easily blow up without too much difficulty. In an ideal world, the bladder would hold urine at a nice low pressure, and then when it's time to go to the bathroom or empty the bladder, it would squeeze and let the urine out completely. What we find is that in individuals with spina bifida, sometimes that bladder is not really storing at a very low pressure, or maybe it's not holding as much as it possibly should. And that can be difficult because as individuals grow, they make more urine and don't want to be in the bathroom all the time. The other thing that we consider is the outlet. And I think of this as the neck of the balloon, where this knot is right here. And that's, if you think about it, the muscles that kind of keep things tight and try to keep you dry. What we find is that there are some patients where the bladder is just not really good at holding all of the urine in. And then we think about, how do we do a procedure to try to make it harder for the urine to get out? And the last type of surgeries that I'll go over are channels for catheterizing. One of the biggest questions I get from families is, do I need to catheterize through, my belly button? And this is a procedure that I'll go over, and it's hard to know who might require that, that's a decision for you and your surgeon. However, I can go over some of the reasons we think about considering such a procedure. So a little bit more about kind of what surgeries might be applicable for each patient. When we think about surgical treatment, there's so many different factors, and it needs to be individualized to the patient and the family. So we think about bladder symptoms. Some patients have a lot of bladder symptoms where they have leakage. They might have urgency where they feel like they need to go to the bathroom. Other patients might not have very much sensation to the bladder. And those things all play into what we might recommend in terms of how best to manage the bladder. The other thing that's useful is voiding diaries. So how often did the patient go to the bathroom? Or catheterization logs. So how often are you emptying your bladder with a catheter? How much is coming out? And all of those things play into how much your bladder can store and how well it empties. And that can, in turn, translate to how we could potentially tweak things to get you dry. And then the last test that most people are familiar with, if they've seen a urologist over time, is something called urodynamics. And that test is a fancy test where we basically look at the pressure and how much the bladder holds. And we can also look at the muscle activity of how well the muscles are sensing. And we also take some pictures that looks at the bladder and what it looks like on x-rays. And all of those things play in to how well the bladder is holding and how well it can store the urine. What we look for, in addition to those things, are the kidneys. As I mentioned, our #1 goal is to think about preserving kidney function and protecting those kidneys so they can continue to make urine and do their job. And so with that, we always like to monitor for kidneys and make sure that they're growing, see if there's any swelling of the kidneys where they might be a little bit swollen, or something called hydronephrosis. And with that, depending on the individual's history, we may be checking for reflux, which is basically where urine might be going from the bladder all the way back up to the kidneys. And that can have some impact because urinary tract infections might damage the kidneys in those cases. So those are some of the reasons we might do those tests. And with that, we might talk about what surgeries might be best for each individual. When? This is a question we get a lot, especially when kids are starting to be in middle childhood. A lot of times the question is when should we think about doing this? And you know, in light of the weekend, I found a really nice quote from one of the families with twins with spina bifida, who said, you know, spina bifida is a snowflake condition where basically no two are alike. And I feel that that is really, really a wonderful way of describing it, because every bladder will act differently depending on the specific characteristics of each case. And then with that, each family and each patient are different. And I think that's important because one child might be ready for a bigger surgery. One child might not be ready, and they might be the same age. We also have to take into account other medical conditions that might be going on. Certainly the bladder might not be at the forefront of our medical attention right now because there's other things that need to be addressed. With that, we partner very closely with our physical therapists and our occupational therapists. And I find that these disciplines are so valuable because they can really give a good sense of dexterity, the muscle strength, and really help give a nice picture of what we might be able to utilize when thinking about kind of how do we optimize things for the future. And lastly, because it's the most important, the patient and the family characteristics. And these are all put together in terms of trying to figure out when might be the best time for surgery if needed at all. So I'll go over a few of the procedures that we often do in terms of trying to help the bladder do its jobs that I just went over. And these are by no means all of the procedures, but they're some of the most common ones we run into. So when I think about storage, cystoscopy is a fancy term for using a little telescope to look inside to the bladder. And if you look here on the schematic, they're using a flexible one that's going into the bladder here. And this is a picture of what it looks like with a tiny camera. And this procedure can be helpful because we use a medicine derived from a little toxin that causes the bladder muscle to relax. And it can be used in all types of muscles around the world, the most commonly known from plastic surgery or facial enhancement to kind of get the wrinkles out. However, in a urology setting, it can actually calm the bladder muscle that tends to have a tonic activity of just kind of contracting. And in patients who have that, it may improve the amount that they can hold, it may improve the amount that they leak might be less, and they may have reduced symptoms if they're having urgency or feeling like they need to go to the bathroom a lot. The benefit of this procedure is that it's minimally invasive, doesn't have any cuts on the skin. However, it can wear off. And after a few months, typically does need to be treated again, but not in all cases. And so that is an option that might be applicable in some individuals. Another option to help with storage of the urine, a little bit differently, is thinking about, do we want to allow the bladder to drain directly into the skin? This is a procedure of vesicostomy, which is often done in younger patients, sometimes if the bladder were really worried about it. This allows the bladder to drain freely to the skin, and it's usually a temporary solution to allow the bladder to calm down, drain to diaper and allow that kidneys to recover. Because sometimes what we find is that bladder is not stretching, it's not holding a lot of urine, and it might be pushing on the kidneys and causing them damage. So this is a procedure that is often temporary. And then a variant of it is a longer-term option for some individuals who might not have the dexterity to be able to catheterize themselves and may prefer a more passive solution where they could attach an appliance, allow the urine to drain directly, and don't have to deal with some of the other things that come with some of the other surgical options. Another procedure that can actually help improve the storage is something called bladder augmentation. And basically what we do here, and you can see in the schematic here, is the bladder is opened up and a piece of intestines or bowel is actually kind of flattened into a sheet and kind of patched on top to allow the bladder to hold a little bit more. And that goes back to our goals. When we're thinking about the bladder, we want to allow the bladder to hold enough urine at a nice low pressure. This is typically done in the past in a more open fashion, but has been increasingly reported with our surgical robot or a minimally invasive way. And oftentimes, if this is being done, sometimes it will include that channel I spoke about through the belly wall to catheterize. And we'll go over that. That's pictured right here in the corner here, so that you could catheterize through either the belly button or the belly wall down to the bladder. Bladder augmentation we'll go over in a little bit, but it is one of the bigger surgeries that we do. And with that, it has some things that we like to review with families before considering it. When I think about outlet, kind of tightening those gates, that neck of the balloon, there's a few different options to kind of help let the urine stay in and try to increase the resistance or how difficult it is to let the urine leak out. So one of those options is a sling, where basically we would take some of the patient's own tissue or another material to basically sling the urethra or the tube that they pee through up a little bit to make it a little trickier for urine to make its way out. And if you look here on this picture, this is the bladder. And right here is the urethra, which is where the urine drains and individuals pee through. And we term this area right here the bladder neck, similar to if your bladder was the head and the bladder neck was where your neck would be. And that's basically where that sling kind of tenses things up a little bit to help allow the urine to stay in the bladder. Bladder neck reconstruction can be done in a few different ways. And this is a way where we basically elongate the urethra, that tube that we pee through, and that can increase the resistance and make it a little bit trickier for the urine to leak out. That may involve some surgery on the ureter tubes to make enough space in the bladder. And again, all of these will be discussed with your surgeon if your surgeon feels it might be a good procedure for you. And then the last one I'll mention is one that is minimally invasive, however, is potentially not as effective as some of the other options. What we can do is we can use our little telescope, cystoscopy, and actually inject a little bit of material to that neck of the bladder like we spoke about. And there's a few different ways this has been described. All of the agents that are used tend to kind of bulk things up to help see if we could seal things so that less urine leaks out. And this may decrease the leakage in some individuals. However, it hasn't proven to be an excellent solution for every patient. So in certain circumstances, it can be very helpful. And then as a final note, I'll mention the idea of a bladder neck closure. This is where basically we disconnect the bladder from the bladder neck and sew things closed. This is a procedure that we typically do not start with because we usually want to maintain the ability for urine to make its way out the way it usually does. And the reason I mention that is that we'll go over some of the things your doctors will be watching for over time to kind of help keep you healthy and safe. And with this, you no longer have another way to empty the bladder. So with that, oftentimes a channel is formed from the belly button to the bladder to allow catheterization and allow the bladder to empty. So this is something that is an option, but usually not the first thing we consider. When I talk about channels, there's a few different channels and people use different terms to call them. The first one is a Mitrofanoff channel or an appendicovesicostomy, which is basically the appendix connected to the bladder. And what you can do is in this schematic, you can see this boy has a stoma. It's right next to the belly button in this particular picture. And the catheter goes through this tunnel to the bladder to empty things out. You can see him doing that right here in this picture from Kids Health in Canada. And the difference between some of these channels is what tissue we use to kind of help form that channel. So if it's the appendix, it might be called a Mitrofanoff. And if it's a piece of small intestine or bowel that's been rolled into a tube, we might call it a Monti. The specific differences of why you might choose one versus the other will be discussed because it does depend a little bit on each patient and their previous surgeries. However, the channels are used to catheterize and allow the bladder to empty. And then I'll briefly touch on a few other types of surgeries. This is not a comprehensive list. However, there are other things that might be done around the time of some of these surgeries to help reduce the risk and achieve our surgical goals. So for one thing, some patients might have what we call reflux. And I touched on this briefly earlier, but when the urine goes from the bladder back up towards the kidneys, that's called reflux, and that may increase the risk of kidney infections. So if your child or if you are a patient with reflux, sometimes we think about treating that at the same time. Sometimes it's been treated in advance. Sometimes it goes away on its own with bladder management. So there's a few different ways that can be treated, and all of those are options depending on each specific needs. Down the road, bladders can sometimes develop stones, and I'll talk about what we look for after surgery. However, bladder stones may happen. Those are little stones that can form from different minerals in the urine, and they can also form from mucus, from an augmentation, because the bowel typically makes what we call mucus, extra sort of fibrous stuff. And then the last thing is bowel management. This is where it's really important to work as a team. And we like to focus with our colleagues from general surgery as well as gastroenterology to make sure that we're addressing both the bladder and the bowel when we're thinking about an individual as a whole. Because neuropathic bowel, or bowel that has been affected, have the nerves affected, can be managed by a variety of services. However, if we do need to have a procedure for that, we try to think about planning so that it could either be done in a staged fashion or together. When I think about preparing for surgery, this is not a very short process. Because these surgeries are a little bit complex, we like to make sure we have a lot of education. Many families will already know how to perform catheterization. However, some families may not be actively managing their child's bladder. And so with that, we want to think about catheterization teaching so that we can learn how to empty the bladder with a catheter. And as children and adults prepare, we like to empower the patient to make sure that the patient understands things that we might be thinking about doing and can offer their input depending on the age. And so with that, we like to go over different informative modules and things that really kind of go over what we might be considering. And then the last thing is thinking about medicines and other medical problems. So we think about medicine management, so that if there's a medicine that might need to be adjusted, we want to think about that. Nutrition is super important, and nutrition is one of those things that can be a little bit tricky, because from the outside, you can't always tell how well nourished a person is. And that's where we like to get our dietitians and also some of our gastroenterology colleagues to ensure that patients have enough strength and reserve to undergo a procedure. And finally, as I mentioned earlier, we like to think about coordination with other care providers. So this is where it's really helpful if all of the providers and doctors who are caring for an individual with spina bifida are on the same page and able to talk freely so that ideas and best practices can be shared, and we can make sure that we're all working together for the health of the patient. So I touched briefly on risks and benefits, and this is just a very brief list of some of the things that I go over when I'm counseling patients and families considering surgery. So when I think about bladder surgeries in particular, we worry about risks of bleeding or infection with any type of surgery, but I always warn that there could be residual incontinence or need for additional procedures depending on what surgery we're considering. If we're working inside the abdomen, there's always a chance that something could be injured nearby where we're working, and we do our best to avoid those things. However, if patients have had multiple different surgeries before, each time we go back in, it becomes a little bit trickier and has an increased risk of having trouble. So that is something I like to be transparent with my patients about the anticipated level of concern or risk. However, we weigh that with benefits. And the benefits of surgery in some cases can be independence with catheterization. That's where sometimes that metrophenoff channel through the belly button or the belly wall can be helpful to allow a patient to catheterize. There's plenty of patients who catheterize perfectly fine on their own and don't require such a channel. However, each patient is different. When we think about continence, dryness, the goal would be to optimize this and try to avoid needing the use of adjuvant things such as pads or absorbent undergarments. And with that comes an improved quality of life in many patients. With that, we want to make sure, as I mentioned with my original goals, that we're protecting the kidney and allowing the storage of the bladder at a low pressure, as we discussed. And those are some of the benefits that we consider. I'll briefly touch on what happens after surgery. So I think it's really important to understand that consistency is key to allow the procedures to have their maximum benefit. So we want to make sure that the bladder is regularly emptied. And in most cases, catheterization is one of the tools we use to empty the bladder. When we think about things that could potentially impact a patient in the future, the one thing after certain surgeries is we do not want the bladder to leak or rupture. And so that's why it's really important to catheterize regularly and avoid any concerns, such as over-distending the bladder. When we think about the bladder, it's not a static organ. It can change. And so as patients grow, there could be things that impact the bladder and might require us to pivot and adjust our plan. So we continue to monitor for changes in the bladder, changes in the kidneys, and changes in the spinal cord, such as a tethered cord. And that's where we, again, work very closely with our orthopedic and neurosurgical colleagues, and they can even alert us if they feel something might be moving in the wrong direction. Sometimes the earliest sign of some of these problems is some changes on the urodynamic study. And then additional management might be needed. For example, if we did a reconstruction where we put that little patch of bowel onto the bladder, we might need a patient to catheterize and flush a little bit with some saline or some water to help get that mucus out to prevent those bladder stones that I mentioned in the future. And so with each of these steps comes additional things that we consider, and we'll be talking with you directly with each surgeon. So there's a few questions that were sent in from families, and I know that one of our colleagues is going to be speaking about medical management of the bladder, hopefully in the future, but I did my best to talk about a few of these things and give my thoughts on how to prevent recurrent urinary tract infections in a child or a patient with spina bifida. The short answer is that there are many signs that can point towards a urinary tract infection. And the ones that I typically warn families about are fever. Obviously, in the current climate, fever could mean a lot of different things. However, abdominal pain, a change in urinary symptoms such as increased leakage or discomfort, and from there, we would want to obtain a urinalysis and urine culture. And I think that this is really important that you have a urologist or someone well experienced with neurogenic bladder on your side and on your team to allow interpretation of some of these factors. How do I protect my child's kidneys? We want to reduce risk factors that may reduce the number of infections and the severity of infections. Overall, it will be a little bit tricky at times to figure out, is this a urinary tract infection or could this be something else? The other thing that allows us to consider intervention would be that reflux that we spoke about earlier. If reflux, where the urine is going from the bladder up to the kidneys, is present, we may think about recommending a procedure to help correct that reflux and allow urine to have only a one-way out to the bladder and out to the world. Surgery can help reduce damage to damaging infections to the kidney. However, bladder infections may still happen based on genetic risks and just patient and bladder risks, unfortunately. However, there are some things we can do to help reduce the risk of infections. What we can think about doing is also thinking about, are these all infections? And we run into this pretty commonly. And all of my patients will tell you that I try to be really vocal about trying to make sure we understand, could this be an infection? Or is this a urine test that might not actually represent an infection? Because when we think about it, we're passing a catheter into the bladder, and that will with it drag a little bit of bacteria and skin cells and things that could potentially cause colonization of the bladder. And that is where I always empower my patients to let their providers and their other care team members know that if they're not having symptoms and someone were to check their urine, this is not something should be routinely treated. It might be positive, it might show bacteria. However, if we continually treat them, we can end up with trouble with resistant organisms and even complications from antibiotic reactions. And so that's one thing I always like to mention. When we think about sterile versus clean catheterization, there's been multiple reviews that look at catheters that are clean is an excellent way. You don't have to do sterile catheterization in most cases. However, there are some patients that benefit from single-use catheters or patients that we would recommend in certain circumstances to change the way they catheterize. And that's for each physician treating each patient. The other thing I'll mention is that urine color or character is not a reliable indicator of infection because this can be impacted by so many different things. How much the patient drank, how much they ate, what they ate, and a variety of different things. And then when you mix in some of the reconstructions that we consider where there might be a piece of bowel in touching the urine, we know that the character of the urine might look very different even though the patient themselves is feeling quite well. So those are some things I usually go over with families when we're struggling with infections. Down the road, there's other things we can offer, such as in certain cases, low-dose antibiotics for a brief period of time. We don't like to do that for long term because of the risks of antibiotics. And you can speak with your own doctor to try to figure out the best way to reduce these infections. So another question we got was, there are so many catheter choices and which one is best? And I will tell you that there are so many different catheters. They are coming up with different ones, it seems like every day. And sometimes the patients have heard of ones that I have yet not seen. These were just some internet searches of some of the different ones. And I'll just mention that one size does not fit all. And I will be the first to admit that there are some patients where the catheters that work for many patients just don't seem to work for them. And this is where I like to empower the patient to think about what worked for them and what worked well, what didn't work well. We have two wonderful nurses that work in our clinic, including one that made a board of all the different catheters and could point out the labels and which ones might work for each one. And that's where I think an experienced team helping you navigate this can be really a huge resource. I'll say that generally as the treating physician, we think about size to make sure that we're using a catheter that is the right size to go into the urethra. And with that, we also think about the rigidity or how firm the catheter might be. We want to make sure that it's not too soft to get coiled into the tube, but we also don't want a very firm, uncomfortable piece to go into the bladder. With some catheters, they're pre-lubricated or coated, and those can be very helpful, especially if the patient has a lot of sensation and has discomfort or burning with catheterization. And the last part I'll mention is some have a bend at the end. That's called a coude. And that allows the bladder, especially in boys, to allow the catheter to go in through the urethra and up to the bladder when there's a little bit of a turn. And so that your doctor might recommend which type and which size. And then from there, the specific characteristics may depend on a lot of different factors, including the sensation and your specific diagnosis. And then the last thing I'll mention is in certain places, a lot of this might be dependent on the insurance, the company, and the supply manufacturer. So I would work closely with your local care team, and they can usually know what might have worked for other patients and what might work for you. So in conclusion, the surgical management of neuropathic bladder is performed in some individuals with spina bifida. Specific procedures are tailored to each individual's needs, preferences, and goals. And I really wanted to thank everyone for the opportunity to talk with you guys about the different surgeries that might happen in individuals with spina bifida. This is one of my favorite things, and I was really happy to participate.
Well, thank you so much. I think that that was a really great overview of very complex considerations, but really explained in a very simple to understand way. So I think this will be a great asset, especially for parents of really young children, sort of to understand what might be ahead of them, what the considerations are, different options, questions to ask. And I think just being a more informed consumer and better prepared going into doctor's meetings, I think this will be a great resource. So I thank you so much for your time. I will put in a gratuitous plug for at Spagni, we do have a lot of catheter samples. So if people are having a hard time getting their catheters because there are supply chain delays or disruptions, please let us know. And if we have something, we can get it to you. But also, as you mentioned, there are so many different kinds. And if people want to try a different kind and see how that feels, if it works better for them, you know, certainly that's what they're there for. So we really encourage people to reach out to us. There's a listing posted to our website of what we currently have in the office. So people are more than welcome to check that out and just send us an email and we can connect with them and make sure that they get what they need, especially a little bit difficult during this time. So we're happy to be able to provide that if needed. But thank you so much for your time, Dr. Dudley, and for your expertise. This is really, really helpful. And I know that this will be a great resource for our families. So thank you very much.
Of course. Thanks so much for having me.
Thanks.